Well, good afternoon, everyone, and kudos for hanging in all the way to the end of the Pediatric Healthy Brain Summit. I really appreciate your involvement and your interaction during this whole summit. Again, it's been encouraging to me to see all the great conversation in the chat box. And I don't know about you, but I would guess for you too, that last panel was awesome, and hearing the pediatricians and their innovation and trying to address real world problems was, again, just inspiring. And I have another inspiring physician with me today, Dr. Laurel Williams, and we're going to talk about mental health here in the state of Texas. Last legislative session, we were given an opportunity to improve how we provide mental health services throughout the state of Texas. Through a bill by Senator Nelson that was carried by then Chairman Zurwas, we were able to establish the Texas Child Mental Health Care Consortium in the state of Texas. And so this is a new tool, a new resource for the state of Texas that I think is really important. And to be fully transparent here, I am part of that consortium. I am a member of the executive committee and currently the presiding officer, but I'm an infectious disease physician. It is great for me to surround myself with all these board certified psychiatrists and mental health experts as we try to really improve services here in the state of Texas. And so let me introduce our guest speaker. One of our speakers could not be here today. There was something that occurred that prohibits her from attending today. But Dr. Williams is with us. And so let me tell you about Dr. Williams. She's an associate professor and chair in the Menger Department of Psychiatry and Behavioral Sciences at Baylor College of Medicine. She's the director of the residency training for Child and Adolescent Psychiatry Fellowship. She has expertise in working with youth who self-injure, as well as those that have chronic suicidality, in addition to working with adolescents who are pregnant or postpartum or suffering with mental health disorders. She's working with the Harris Health System to develop protocols for family-centered mental health care. And she serves on our executive committee of our new Texas Child Mental Health Care Consortium, and actually has a key role. As we put this consortium together, we decided that there needed to be consistency across our institutions. We have 12 institutions that are actively participating in this right now, and we needed to make sure that there was consistency. So we developed this centralized operating support hub, what we call a COSH, but a centralized entity that can provide medical direction, a systematic approach to data and the phone lines and marketing and a variety of things. And Dr. Williams serves as our medical director and the leader of that centralizing operating support hub. And so intimately involved in this consortium, very involved in the national discussions of how do we improve these type of services throughout the nation, and in the real world practice of improving mental health services for kids. And so I'm going to hand off to Dr. Williams and let her present the work of the consortium, but would like to make sure that you are aware of this work. And if you have questions, we want to make sure that there's ample time to answer those questions today, so that this is a tool that is available to you. We're going to put, and I think it already has been put in the chat box, a link to the website on the consortium, and I would encourage you to take a look at that. And again, a tool that's supported by the legislature to improve mental health. And we've heard throughout today and yesterday the role of mental health and the need for mental health services for our kids and our moms and others throughout the state. So Dr. Williams, let me hand over to you and hear about your great work.
Well, first thing I want to say is actually thank you to Dr. Lakey. He's been inspiring. I know he's definitely an infectious disease expert, but what he's really expert in is helping us build a cohesive collaboration across the state. And he's being modest about sort of his role in really helping move this project forward in such a productive way. Every time we meet as a consortium, I'm just very inspired and excited that we really are coming together as Texans to really help solve a challenge and problem. And this Pediatric Brain Health Summit is so important, and I'm very happy to participate. I'm sorry that Luanne isn't able to be here today. I'm going to show her slides and do my best to speak on her behalf for the things that she was going to share for our group effort today as a team effort. And I just even want to just focus a little bit on this idea of community. As a child psychiatrist, what I've learned over the time of being in this field is we do this work when best when we do it together. And children are not an island in of themselves. And I really feel like actually child psychiatry was mislabeled, and we should have been called family psychiatry. My dad's a family physician. He just recently retired. He'd been in practice for over 30 years in Texas, up in the Arlington area. And I just saw it day in and day out. The way that you make meaningful change for people is you actually work with their caregivers and everybody, and all together we kind of do our best. And so a lot of what we're going to share today is that idea of what can we do in Texas to really take our services to the next level. And if anything, I just am so excited about the collaboration. So I'm going to switch to the share screen and show some slides, and we're going to get through them, share information, and then I'm going to end hopefully with at least 15 minutes so that questions that you have as I'm talking can be brought up. And then Dr. Lakey and I will field those questions and hopefully send you into your Friday with sort of excitement and enthusiasm for the new work that we're doing within the consortium. So can everybody see the slides? Dr. Lakey? Yes? Great. So the Texas Child Mental Health Care Consortium was created, as Dr. Lakey said, through Senate Bill 11. And the vision of this consortium is that all Texas children and adolescents will have the best mental health care outcomes that are possible. We really wanted a vision statement that was very expansive and thinking big. This is Texas after all. And we understand that the way we do that is actually through this sort of down here at the bottom, leverage of health-related institutions of higher education, community mental health organizations, nonprofit organizations to come together to really improve that care and work together. So this consortium is extremely important. And I think from day one, we've really worked to make sure that all voices are included and heard as we've been developing the programs that the law has outlined for us. So today I'm going to Luanne's sort of part of the presentation today is these 5 things. And so I'm going to discuss each of them briefly, and then I will move into sort of talking more specifically about the Child Psychiatry Access Network, as well as the Texas Child Health Access through Telemedicine. We call the first one CPAN and the second one Tchat because otherwise it's a mouthful. So the Child Psychiatry Access Network, as you see here, comprises of all the different health institutions in the state of Texas into hubs that cover regions of the state. And we have a one phone number network so that when a primary care physician, whether they're a pediatrician, a family doc, nurse practitioner, physician assistant, who's working in that primary care role for a child, has a need during their day and they need help trying to decide what to do, how to help that young person, then this network is up and running now. It's actually been up and running since May 18th. And we're busily, steadily enrolling practices across Texas. But this is one of the elements of the consortium is that we are working to have this network stood up. And like I said, in a few minutes, I'm going to actually discuss that in much greater detail. But here's the map. And as I said, you can see that it's really a team effort and all of our institutions are working closely together to make sure the experience for that primary care doctor, regardless of where they're from, that they'll get the same high quality experience and assistance when they call us. As I said, the next initiative is the Texas Child Access through Telemedicine. And this was in part based on some success up in the Panhandle. We do know that mental health can be hard to find. And we also know that, where children sit most of the day is actually at school, despite COVID and the challenges we're having with COVID. But this idea has been shown to be successful differently in rural communities. And so what we wanted to do is expand some of that current initial success with some programs up in the Panhandle and move it out to across the state of Texas. And so what happens is that we have direct telepsychiatry or telecounseling services to schools for the students on their campuses. We also provide education and training for the school staff. And really, we're working to have a statewide data management system to really help us understand the families and kids that we're helping and ways that we can improve the program moving forward. The next piece of the consortium is something called the Community Psychiatry Workforce Expansion. It's a bit of also a tongue twister, so we call it CPWO. And one of the things that's really important about this is that we know that we need child psychiatrists and other child mental health professionals here in Texas to work in some of our community-based services and some of the underserved areas. And what we learn is that when you're in training, if you don't have access to a quality rotational or educational experience, you're not always aware that that might be a place you'd like to work. So this actually is about putting fellows and residents who are in their training to be psychiatrists or child and adolescent psychiatrists into our local mental health authority systems to really have a quality educational experience. And what we know as a child training director for sure is that if I can put a fellow in a location and they can really discover this is their passion, then they're more likely to take that job once they're done with and graduate. So we're really hoping that this will allow for more children to be seen within the LMHAs, as well as convince some of those learners that once they're done with training, that they want to pick one of these locations for a job moving forward to really help our community get stronger when it comes to mental health and mental wellness. So we have of the all the LMHAs in Texas, we have 31 of the 40 who are willing to participate. We already have 17 LMHAs who are working, and we're working across the HRIs to actually expand that out to those additional programs that are willing and potentially want to participate with our teams to provide that educational experience and that ability for families to get that care. In 2020, we actually already have 20 additional psychiatry resident positions available because of this workforce expansion, and 12 academic faculty who are being embedded in these LMHAs to really make that be a high quality educational experience, as well as obviously a superb clinical experience for the patient and their families. This next one is also near and dear to my heart. I've been a training director now since 2009, and one of the things that we across the nation struggle with is that we need more of us. The mean age of child psychiatrists, and I'm kind of starting to be in that age group, is not going down, it's going up. And so we're actually retiring sometimes more people than we're training. So this has been a really boon to Texas, that Texas has been willing to invest. And what we do know is that fellowship is the last sort of stop for most physicians in training. And so we do know that if they can have their last stop be in Texas, then they're most likely going to stay in Texas and see patients and care for families after that. So this has been really excited to see some new programs can stand up from scratch, as well as just have additional fellowship positions within the current fellow programs, such as Baylor, for example. And last year, we were able to get 2 new fellows into our class. And I think what we're hoping is all the HRIs are going to have that type of experience, both adding new programs from scratch, as well as getting more fellows. And in the end, that's going to translate into more access to care for the kids and families that we serve. We do know that this is a kind of an aggressive expansion, and there's definitely a shortage of applicants for child psychiatry, but we're going to do our best. Texas has a lot of nice qualities that make people across the country want to come here and train. So I am very positive and confident that the more we can show those individuals across the country why Texas is such a great place to be, we're going to really be able to fill those positions and help those families down the road. And then this is our website. And so Dr. Lakey had asked for the sort of the website address to be put into the chat box, but it's under construction. We will have a new website in the coming months, but this is the first from the get-go, from scratch, that the team really did an expert job pulling together. But if anything I talked about today you want to learn more about or just get some more information, you can go to the website and see it, and you can sort of see all the different pieces that I've talked about today. So now I'm going to move on to sort of what was going to be my part of the talk, which was I've really labeled this in a way that I hope is positive, but actually does say that there's work to be done. And as a call to action, children's mental health is key to overall health. I just feel very strongly that if we do not help kids and families be at their best emotionally, mentally, they can't do the other things in life that they want to do and achieve. So I'm very much of this opinion that what CPAN and Tchat can really help us do on the ground level from day one of these programs is really improve children's mental health and their families. And we're going to make successes out of that as a result. So I do say that I have no financial conflicts of interest, but as Dr. Lakey said, I am the medical director for COSH. So of course, I have a great interest in making sure that we achieve these aims of the initiative. And several of the slides today actually are contributions from Dr. Noon Tran. She is our Texas CPAN pediatric consultant, and she's very active in the Texas Pediatric Society. And we're so thankful that Dr. Tran has agreed to help us in thinking through how we make sure these programs really help both kids and families and the primary care doctors that we're going to work with in CPAN. So I have a few things I'm going to get through today, and I promise I will get through them in enough time that we will have a time for good discussion and conversation. But I actually want to start talking today about the percentage of youth with mental health disorders briefly. And then I'm actually going to review with you an allocation of the child psychiatrists that are in Texas. Next, I'm going to move to what does the actual American Academy of Pediatrics recommend when it comes to pediatricians managing mental health disorders. And then I'm going to talk briefly about the data that actually shows us that statewide collaborative care models are effective and can be successful. Then I will move to specifically describing the Texas Child Psychiatry Access Network, how it runs and operates, and what people can expect from it. As well as then I will move to describing the Texas Child Health Access through Telemedicine, or Tchat, and sort of tell you kind of our first steps that we've been able to achieve in actually a pretty short time in the midst of a global pandemic. Once again, saying hats off to our entire team for making all this work with so much challenges, that headwinds, I guess we could say, that the whole world is having to struggle with currently. So you may already know some of these facts, but I really just want to sit on this slide for a few minutes, so bear with me if you don't mind. But 1 in 5 children from the ages of 12 to 18 live with a mental health disorder. And we do know that upwards of 30 to 50% of teenagers who are depressed are not getting treatment. And so, as I said earlier, we know that mental illness affects all aspects of our health. It affects our physical health, our eventual abilities to have employment, our abilities to finish and achieve educational success, and finally in our relationships. And we know that when it comes to depression and anxiety, which are the most common mental health disorders for both children and adults, that there are treatments that are evidence-based and effective, both psychotherapies and occasionally as needed medical management. And we do know that we can help people get better. But if we don't help them get better, one of the things that's an unfortunate but very serious epidemic, in my opinion, is that we have the second leading cause of death for youth in America is suicide. And I really, every time I say that, I get surprised all over again. And I really want us to focus on this idea that suicide largely is preventable if we can actually work on solving and helping that young person with the root causes for why they felt suicidal or hopeless and have thought about ending their life. So suicide is more common than pediatric cancers as far as death, cardiac disease, congenital diseases. It's actually more common than, unfortunately, homicide in the United States. When you look across the country, about 50,000 people across the country every year are a victim of homicide. Suicide. But for homicide, it's actually 20,000. So we have 2.5 times the rate of people dying by suicide than dying by homicide. Now, both of those types of deaths are tragic, and we want to help find the ways that we can avoid them. But I just feel that sometimes the outcry for mental health and suicide in particular is sort of drowned out by other things. And I really want us to talk today about it, because CPAN and Tchat can be interventions that can be part of the solution, not obviously the only part of the solution, but part of the solution in really helping those young people. So I really want to make sure that we're really paying attention to that. Unfortunately, the rates of suicide have actually been rising in the last decade, not decreasing. And demographically, there are starting to become more completed suicides with people of color. We do know that people of the LGBTQ community also have higher rates of both attempts and suicide. So we really do need to pay attention to the root causes so that we can help people have hope and not see suicide as an option, because I do think that many suicide deaths are preventable if we're just asking and talking about people's mental health and mental well-being. So I know I spent a lot of time on this slide, but I really think that it's important for us to make those connections to really understand why programs like CPAN and Tchat can be so invaluable to the work that we're doing across Texas for youth. And then the sad fact is, as you see here, the allocation of child psychiatrists in Texas, this comes from the American Academy of Child Psychiatry, is pretty dismal. Now, much of the country actually is in the red, but what's even more unfortunate for Texas is, given our geographic size, we have more counties than not that have no child psychiatrist in the county even. So we are desperately behind when it comes to having enough child psychiatrists. So for primary care physicians who are just hoping that eventually the child could go see one of us, that hope and that may be too long. And that's why we really need to advocate strongly to help PCPs be upskilled and have real-time support so they can help manage some of the mild to moderate cases, so that when we have those young people that are in more crisis, have more severe persistent disorders, myself as a child psychiatrist, I have room in my clinic and schedule to help see those families. So this slide is really the reason for why, I think partly the reason for why Texas has made this bold step is that we need to train more child psychiatrists. We need to put them in quality educational experiences so they'll stay in Texas and pick these jobs. And we need to help upskill the pediatricians, as I'm going to say in a minute, to partner together to really give kids and their families what they need when it comes to treatment across the spectrum of illness. So hopefully I'm convincing you a little bit about my next slide, which is that in actuality, child psychiatrists need the primary care physician to help save the day. As a child psychiatrist, there's not enough of me, and so I'm going to need to partner very closely with those primary care providers. We need you to put on your cap, your mask and your cape and get to it. And again, my dad is a family physician. We have this conversation all the time about his frustration of not having the ability to talk to a mental health provider quickly enough to get assistance and help. And so I'm really hoping that what we can do with CPAN is do that. But it does mean that I am asking an already very busy primary care doctor to perhaps do some task shifting. I'm really moving from that, what you do great, which is the screening process, to actually moving into doing some first line care and targeted interventions, both psychosocial interventions as well as potentially targeted medications when indicated. So we really need that primary care doctor to once again come to the rescue. We'll be your Robin to your Batman, okay? So we do know that this means adding some clinical skills that maybe a lot of primary care doctors don't feel particularly comfortable with. And so that's part of the purpose of CPAN, is to really help. But when you look here, this is actually not me talking. This is the AAP saying that these are the mental health competencies that they expect and hope for primary care pediatricians to have, and so that they can actually do primary, secondary prevention, assessment, and treatment, and work, as I'm saying, in this a collaborative and consultative relationship to really build a program and a system that can provide that mild to moderate assistance that can really make the difference sometimes to keeping an illness from becoming more severe, chronic, and persistent. So it is a big task, and we understand it, but hopefully what I've convinced you a little bit today, although I probably didn't need to do too much convincing, is that why we do mental health in primary care is that, again, the burden of mental health disorders is great. Mental and physical health problems are interwoven. The treatment gap, as I said, is enormous. And you, as primary care physicians out there in the world today, you have a special relationship with your patients that really can help them. And again, I think about my dad, and he just retired this year. And so much of what he's missing about his work is not the EMR. It's the knowing how his families are doing. And he was an old school family practice doc who actually delivered babies. So he actually got to see people who themselves had babies and were growing up, their kids. And so I just think that primary care relationship is so special. And you can help bridge the gap with the stigma that still persists around mental health. And we do know that there's things that you can do as a primary care physician, a provider, who can help. And so we want to help you with that. And that's why we're saying primary care is where we need to go when it comes to bending the curve to getting more people help and assistance. We know there's barriers, there's kryptonite. There's obviously the lack of training. Pediatricians, whenever they do a survey about pediatrics and family practice as well, they do feel like they do not have enough training. There's the concern about reimbursement, lack of knowledge. And then again, I think some of these things are actually around stigma that we as primary care physicians and child psychiatrists together can help combat, because there really are actually evidence-informed treatments that work that you can do. And so we want to partner together. So think of CPAN a little bit as the steel box that, you know, goes around the kryptonite that you have so that we can be an effective team and get those kids the help they need. So this is a sort of an idea about how you do integrated care based on needs. And it's a busy slide, and I'm not going to go through it in great detail. I'm actually going to skip to doing this. I'm really asking for those primary care physicians to work in quadrant 1. There certainly are different, there's other quadrants here, but I'm really focusing on this idea, I think, as you've heard me say a couple times already. We're not asking a primary care physician to work with a complex, severe mental health disorder necessarily. We're asking for them to really help them learn how to manage depression and anxiety in its various states along with ADHD. And so Dr. Tran, who made these slides, really what she's focusing on is like, I really want to help pediatricians and family docs feel even just more comfortable with anxiety. They're anxious about treating anxiety. They're getting pretty good with ADHD, but they're still really kind of feeling uncertain about anxiety and depression. So here is where CPAN can really be effective, because we can come in at that quadrant 1 and really help the PCP learn these skills and help the families. If you want to branch out and do more things, and you may actually be working in care settings right now that are in those ways, but one of the things I really like to pay attention to is just because you're sitting in the same office or building does not actually always mean that coordinated care is happening. You know, if you have a coordinated care integrated clinic, your behavioral health specialist may be as busy as you are, and they don't have the time to stop and have you answer questions or help you. But that's what CPAN is for. So even if you're in an integrative care system, I think CPAN will still be really an important tool for that team. So the Child Psychiatry Access Network, or CPAN, we are modeled very closely after the Massachusetts program, which has the longest standing state program in the country at over 17 years and running. So if anybody wants to see what a program is really mature looks like, I would direct you to their website. But what I can tell you is the Texas CPAN network is modeled very closely after MCPAP. We've had a lot of great conversations with them about what makes their program successful, so that we make sure that the program we've built here in Texas will also be successful. And as I said, there's lots of actually evidence that these programs work. So I'm going to very briefly talk about these 2 articles. You can go and look them up if you wanted to see them in more detail, but I'm going to go to the right of this screen for a second and really talk about what is the primary care provider's perception of using CPAN. And basically, it's what the first one says, that they do feel that being enrolled and involved and engaged in their network enhanced their ability to deliver mental health that was consistent with family preferences. I know that as a child psychiatrist, I get sometimes a lot of no-shows in my clinic, depending on some of my locations. And I think sometimes that no-show is a lack of understanding about or fear about seeing a child psychiatrist or a mental health professional. And the comfort level of families sometimes is to maybe keep it with the primary care. And so if we can really help, and this is what this article is saying, is that these PCPs began to have improved knowledge and skill, and they were able to take that knowledge from one case and move it into a next case, which is really what we're hoping for. One of the pieces that we want to really work hard on is this number 3, is that how do we engage the PCPs in educational opportunities outside of that one phone call what they make about the patient. So we're going to have webinars. We've already had several. We're going to have videos that we're going to have on the website that can really help PCPs. So we're really going to work to have a multi-educational strategy. But the phone call itself is, again, targeted to really help you in the here and now for that primary care doctor who needs some help right now. As my dad said, his best time of the day, or not, depending on how he wanted to look at it, was Friday at 2 p.m. He needed help and he didn't know who to reach to. And now I can say, well, you can call CPAN, Dad. When you look to what do the families think about it, so this is the second article. If you're worried about, well, I'm worried about, will the family think that about me if I'm calling and asking for help or advice? Well, I'm here to tell you that if you are a primary care physician in this audience, you're actually going to have your patients think more highly of you that they know that you want to get the answer right and you're going to speak to an expert. And so there's actually high rates of parental satisfaction with the primary care physicians who utilize the service. And that what families say is actually strengthen their relationship and trust in their primary care physician. And so I think that makes sense to me. You're already a trusted source. And if they see that you care enough to really check out a question and really think it through and get an expert to help, that actually just improves their confidence overall. And we know that a lot about how we help people get better is within the relationship. And so I think these two articles really point to how a CPAN program can be very important and effective in sort of turning that bar around when it comes to getting access to care. And so as I said earlier, this is our network slide with all the hubs. For example, the Texas Tech up in Lubbock has a pretty large swath of Texas, but that's also, you know, one of our more rural parts of the state. So the population-wise is not as dense. But down here in the Houston area, actually UT, Houston, and Baylor actually collaborate within the system that we are working on because the population is so dense. There's actually enough PCPs and families that we can have sort of two hubs in kind of one region. And what I really like about CPAN overall is that we all are working together. We see this as a collaborative team effort. And I'm excited to say that this 188-901 CPAN number is very easy for PCPs to call and get help. So what do we do? Well, first thing I want to say is that because of the state, this is at no cost ever to the primary care physician or the families. And that we have a process where you can enroll prior to making your first phone call. Or if you wanted to make your first phone call and enroll, we could do that. Or if you just want to make your phone call and then later enroll, we could do that too. But we will ask for a bit of information about your practice so that we can make sure the next time you call, we can be really efficient if we need to send you information via, you know, a phone or a fax or something. And we have a data management system that will keep your patient's confidentiality to make sure that when we're talking to you about patients that we're not talking out of turn. As I said, we're going to work on these other kinds of educational activities, what we call team-based learning with an ECHO project, which is basically small group learning through a video format. We have webinars that are already available, and we're working steadily through some best practice algorithms. Again, what's so great about Texas is we actually have so many well-regarded physicians, scientists in our state that have been generous with coming up with all the things we need to make sure that we put out the best, most evidence-based information for families and for the primary care physicians. The website itself, as I said, is still under construction, but actually I hope that helps you kind of keep going back and looking at it periodically as we keep updating it and adding new information as we get it. I like to say that the service is actually one team, one phone call, but you get 3 services in that phone call. So we can help a primary care doctor with resources and referral assistance. So let's say they're pretty comfortable about what the diagnosis is and what the child may need, but they're struggling to help find that resource, then our team can help you with that. We also can help that primary care physician with some coaching with one of our therapists about maybe a psychosocial intervention you can do in 5 minutes or so in that sort of very busy practice that most primary care physicians have. And then finally, if what you really need is like you're not exactly sure what the diagnosis is, or maybe you do and you tried an intervention that's not working, or you need some more help about thinking about that intervention, then you can speak to a board-certified child psychiatrist. And we actually put a metric on it because we want to, meet the needs of the families and ultimately, and the PCPs, is that we will call you back within 30 minutes if that's who you want to speak to as the child psychiatrist. So as I said in that previous slide, we're available Monday through Friday, 8 to 5, barring state holidays. The first phone call that you make to us, we will get back to you within 5 minutes or less. And then, as I said, if a primary care doctor wants to speak to that child psychiatrist, we will have that physician available to you within 30 minutes to discuss things such as assessment, diagnosis, and then treatment planning, and not just medications. One of the things I really sometimes dislike about the reductionism about child psychiatry is that all we do is meds. That's absolutely not what I do all day long. And so we're happy to help that primary care doctor think through a full array of interventions that may be helpful and actually family-centered. What is the family's preferences? What do they want? And so that's what we're really there for when it comes to the CPAN network. So for those of you who might want to kind of be joined into our networks, I'm giving us a few minutes here. We have a Facebook page for the Psychiatry Access Network. So feel free to come onto our page, like it, and start following it. We put information in about child mental health topics a couple times a week, as well as whenever we have any educational opportunities that people might want to know about and be aware of, you can find them on our Facebook page. And the same thing holds true for our LinkedIn page as well. So for anybody who wants to join or be participatory in Facebook or LinkedIn, nowadays with social media, I really am sort of encouraging you now to take this information down and come say hello to us in our social media page. And then if anybody wants to just see this talk done real quick in 3 minutes with Dr. Tran and myself, we have this 3-minute version of this talk that I'm giving you right now to really tell you about CPAN and what it is and what it does. So I'm going to move to the last part. I told you I'm going to be done in time for questions and a good, hopefully, discussion. The Texas Child Health Access through Telemedicine. I just have a couple of questions up here that I'm going to help answer, but I think you know the answers to themselves. But why do we have this idea is that where are kids during the day? Well, hopefully they're at school. And what we want to try to do is help, get them care quickly if they're having an urgent mental health need. And also, where are parents during the day? Well, they're often not at school, they're at work. And so a lot of times it's really challenging for families. And I have families, because of where I sit in Baylor, we have families sometimes drive 3 hours to see me. And I really, feel for them because that's a whole day's lost work. That's a day's lost at school. And so this has been really a nice program that the state has allowed us to start implementing, because we really are trying to meet those needs of those kids and those families and really help decrease the stress and improve the access that they have. And I just had to put this during a pandemic. Does anything still make sense? Well, actually, what we've been able to do quite nicely is pivot to doing telehealth directly into families' homes. So the referral comes to us, has to come to us through the school process. But once the school refers the patient to us, we actually now are doing a good percentage of our care actually in families' homes. And I think that families do appreciate that flexibility of access. We do know that sometimes the urban versus rural areas have different needs, and particularly in rural when it comes to broadband connectivity, we will plan to still have practice where it happens on campus so that in case a family does not have a good internet connection at home, there still is an opportunity for them to get the care. They would come to school. At least here in Texas, down in Houston anyways, I should say, we have a lot of our campuses are not allowing for other people to be on campus right now. So even if they're doing in person right now, other people cannot come onto campus. So like parents couldn't come to their appointments and whatnot. So we're actually still excited that we have that flexibility to see kids either on campus or through their home if they need to. So what I really think Tchat does, which is fantastic and wonderful, is that it's a part of the Texas solution. It's not the only piece, but it's a part. It's timely, we are evidence-informed, patient-centered, and we are partnering with the PCPs, the schools, and the local LMHAs to really try to make a comprehensive approach. Because as I said, and I've been saying over and over again, we're not going to get this done with just one team doing the work. So for example, as the families give us permission, we want to feed back to the school, here are some things that might really help this patient after we've seen them for that short visits, so it can really help them be successful. If they have a mild to moderate sort of disorder that we've been able to help them with, then we might want to hand them off to the primary care physician, and then through CPAN, continue that collaborative relationship so the family can keep getting the care they need without having to sort of escalate to specialty care. And the primary care doctor has the confidence that their Robin is helping them when they're in their sessions with the kids in their clinic. And then finally, also sending these young people after this short-term program that Tchat is to a local mental health care team, so kind of helping the burden of some of that urgent care. So we really do think that Tchat is one of a very important mechanism to help provide access to care when there is a struggle of finding that kind of more timely access. And to that end, the state really paid attention to this idea. This isn't care forever. It's a short-term intervention. So we have up to 4 appointments with the family, and then we need to help them collaborate with another team if they need ongoing care. And that's what's really important, because it will allow us to keep seeing new patients versus getting full up and then not being able to accommodate those new families when they're coming in with an urgent issue. So Tchat is not meant to be, it's not designed to be long-term care, but it is, I think, a very important puzzle piece when it comes to helping Texas youth. As you can see here, here's a Google sort of map of the locations of the different HRIs and the different school districts that we've already started to partner with. And we're working on our next phase of moving outwards from these current affiliation agreements with the ISDs. And we're working closely with the TEA as well and their educational support centers to really make sure that we're not doing anything that's double dipping, or not double dipping, but duplicate efforts. I mean, to me, it'd be a failure if I'm doing Tchat and right down the road, somebody else is already doing a service that's been helpful. We want to go into those places where the kids don't have services, the families don't have services, and that's where Tchat can be its most effective. So right now, across the state, across all the HRIs, we have over 96 ISDs that we have signed agreements with. Even though COVID has made starting this a little bit slower than we would have liked, most of our teams across Texas are up and running and seeing patients. And we have, this is actually an old slide, so I know the number of referrals is even higher than that. We have a statewide patient platform for patient engagement where we can track their outcomes and the families can see their outcomes. So that's the other thing about mental health care that I really want to focus on is transparency. The families are a partner with you. And so this platform actually allows the family to see how the child is doing. And we work together, even within that brief amount of time, to really help those families achieve their goals that they came to us with in Tchat. And again, that aftercare planning that we can connect with CPAN, we can connect with CPWO, that workforce expansion of rotation. All these things is really about that idea of coordination and collaboration. So Tchat has a role to play. We're not sort of we're not kind of being bigger for our britches. We really think that we're going to fill a niche that's necessary to kind of help that overall continuum of care when it comes to youth and families in Texas. So I'm going to stop now, and I got there almost exactly on the time. Thank you so much for this opportunity to talk today about the consortium overall, and specifically about CPAN and Tchat. And I'm going to stop sharing my screen and allow for questions so that we can have a nice discussion leading into the afternoon.
Thank you, Dr. Williams. I think that was great. And again, good overview of this brand new service and resource that we're trying to bring through the state of Texas. I guess I want to start off with one quick comment question, and then Dorothy, it looks like you may have the other questions lined up. But I think it's important as we talk about CPAN of who the customer is, and maybe just an additional emphasis on who the customer is and how we're trying to support that customer to be equipped to provide these services.
So who the customer is the primary care physician. We are, because again, the idea there's not enough child psychiatrists, we need to upskill and help improve the knowledge of the primary care physician. So the person who's going to call the CPAN network is the pediatrician, the family doc, the PA, the NP. That's who's calling. And then with that consultation on the phone, they're going to go back to that family and they're going to discuss treatment options that are hopefully family-centered, values, and evidence-informed.
And I say that just because I think it's important that what we're trying to do here is equip the primary care physician to care for the kids that are coming to them, that they don't need to be referred out to the psychiatrist when given the type of support they can get through people like you across the state of Texas to guide them on how do you care for this child. And the learning that takes place equips them then to take care of additional kids in the future. So Dorothy, why don't we start with some of the questions that you have?
Yeah, so I think this is a related question because it is about who the customer is of CPAN, but there are a couple of questions in particular that ask specifically about how CPAN can help, especially with infant and toddler, to address that entire family unit. And so some of the questions are focused on what kind of resources can they get for especially the infant toddler period where you see some breakdown within the family unit.
So our age group is really, as child mental health providers, I think we have down to that age group and upward into the sort of early, right after 18 kind of age group. So if you call CPAN and you have somebody you need help thinking through that problem of like you said, a family breakdown, or is this child not, there seems to be a challenge this child is having, what do I do about it? then we can certainly help connect you with some resources. So those primary care doctors, if they're in that age group, they can certainly call us and we can help them think through what is the question that they have and what resources that child and or family may need.
And to build upon that, we are in year one of really getting this going here in the state of Texas. But if you look at some other states, they've developed a CPAN for moms, where they've been able to piggyback on this type of infrastructure to then provide perinatal mental health services to moms and their families. And I think that's, as we look in the future, something the legislature will want to think through. That actually was put into the HHSC's strategic plan for perinatal mental health, to build upon a structure like this so that moms that are taking care of those infants can get the services they need. And again, not bringing them in to see the psychiatrist, but supporting that OBGYN physician, family medicine doctor to be able to care for people in their own clinic.
So the other question that's been coming up too is about how you guys incorporated and utilized the PCP, especially the pediatric voice, in developing the training as well as developing CPAN, and how did you make it so that your customer was the center of the network?
So we started right off the bat with talking with pediatricians. I think the TPS has been really instrumental in helping get CPAN up and running. And as I said, this is actually not a new idea. 36 other states in the country have a network. So we actually were able to rely on other networks about what worked and what didn't for those customers that you're speaking to. But that was why I felt it was very important to have Dr. Tran be a consultant for us, because we really want to make sure she's in all of our key meetings to really make sure that we're keeping that focus on what's going to help that primary care physician.
Yeah, from the beginning, we've tried to work very closely with the Texas Pediatric Society, because the pediatricians are the customers, family medicine doctors are the customers. And so they have been, from the very beginning, working with us as we've designed this to serve them.
And so several questions also coming up. You gave the link to Facebook and you gave the link to the LinkedIn page. Is there any other place that we could either cross post or make sure that the physicians on now know how and when training is coming up and how to get on to the training? So
the webpage, the consortium webpage as well, has information such as that. And each of the individual HRIs, so the hubs, those hubs I talked about, going to those individual hubs, they're developing their own Facebook web pages, and they're reaching out to their network. We actually also have a relationship with TPS, where they are going to start helping us put the message out in coordinated ways, as well as the Family Practice Association of Texas. Tom Banning's team has been super helpful. So we are working to coordinate across sort of multiple efforts to make sure that information is there. And as far as trainings, again, give us a call. We're happy to help you think about pretty much anything related to children mental health. Giving us a call on that network, that phone line, is certainly one way to do it.
And we're going to post that phone number again so that if somebody didn't have it, and we will post also the Child Mental Health Care Consortium website as well. So in case somebody missed it, you can click on it and go to it. Some of the questions also center around reimbursement and coverage of these services. And I was wondering if you guys could speak a little bit to that.
I can jump in first, and then Dr. Williams, you can jump in. This is a state program. It is funded by the state of Texas to make these services to everyone, regardless of their ability to pay. And so when that psychiatrist is calling Dr. Williams, Dr. Williams is not billing that primary care provider. Her funding is coming from this line item in the state budget. When the school is asking for help, the way it's functioned right now, again, our psychiatrists are funded line item here by the budget. There isn't a bill to that school to provide those services. In addition, the other part we haven't talked a lot about so far is the partnership with the local mental health authorities across the state, which gives us the ability that if that child, on the fifth visit or so through CPAN really needs to see a psychiatrist in person, we can refer to that local mental health authority and have our resident partnered with a academic psychiatrist there in the local mental health authority to provide those services. And again, do it without having to charge that child for these services. So this is available to all pediatricians, primary care providers to support any child in the state of Texas. Dr. Williams, anything you want to add to that?
No, as I said, I just feel like it's phenomenal. This is something, as I said, you're not going to be charged for as a primary care physician. The families that are seen in Tchat are also not charged. The schools aren't charged. I think this is very, really wonderful and instrumental that the state is getting behind this and supporting it.
And I guess the other thing I would add, looking at some of the chat, there is misinformation about mental health. There's stigma related to mental health that's not founded in current care and science. And so being able for the Dr. Williams of Texas to provide that service to the primary care provider so the child can get the services at home in a place that they feel is very comfortable, I think will be really important for that child moving forward. Dr. Williams, any thought about that?
Yeah, I mean, the other thing I didn't say in the talk is that you don't have to have a patient in your office to call us. So let's say a family has sent you a message, either MyChart or a phone message, and you're not sure how to handle it, how to have that phone call back to the family. You can call us and we can help you think through what might you want to do or say to help that family. And again, the education that you get on the phone is a targeted education based on that very specific question that you call us about. We're going to have other opportunities for other kinds of trainings and education that will be more broadly focused on a topic, and then people can come and listen. But a lot of what we do in medicine is this idea of see one, do one, teach one. And the way that you learn to do this work is to talk with another expert about it. And so that's what's so essential about CPAN is that primary care physician. Again, I just think about my dad. He can pick up the phone at 2 p.m. on a Friday when he doesn't know what to do with this patient in his office, and he can help have a conversation with somebody. And we'll have that conversation as brief or as long as that physician has time. And what we want you to come away with is I now know something I didn't know. I have a direction that I can go to with this family. And that is so instrumental to both the primary care doctor, but selfishly to the patient in the end, right?
Well, I also want to thank Laura Young, who I know is part of the hub in East Texas, for answering a lot of the questions in the chat. Thank you so much, Laura, for handling and for putting that phone number back into the chat for us as well. And Dr. Williams, I want to thank you so much for coming and presenting to us and talking more about this incredible resource that we have in the state. And I am with you. The more we can use it, the better kids in this state are going to be able to end up health-wise. So thank you so much. I really, really appreciate it.
Thank you.
And Dr. Lakey, of course, I'm happy to have you.
Thank you all. It's good to be here.
So I'm gonna remove you too, and I just want to end and let everybody know that to remind everybody that that if you need to contact us and about your CEs or about anything else, please do not hesitate to email either Sarah or myself. And this is our email addresses once again. Whether it's that you can't figure out, you haven't received the email about your CE evaluations, or you just have more questions, please feel free to reach out to us. We're happy to have you. And we're happy to get your emails and happy to answer your questions. And I just want to say thank you to everybody who attended, both yesterday and today. We've had a really fantastic day, and a lot of it has to do with the amazing interaction of you guys have been doing. Thank you so much. I really appreciate it. And with that said, we are going to end the summit. Thank you. Bye.